And we're going to shift gears a little bit and get into the practical issues of PrEP. And I can't think of anybody better than our next speaker, Dr. Hyman Scott, a physician researcher at UCSF and the Department of Public Health in San Francisco, has a training at UCSF as a chief resident, ID fellow, got an MPH from Berkeley at the same time, and now really works in the community, especially among gay men in San Francisco, and especially with disparities, trying to find the best ways to test for HIV, test for HDI, link to care, and also for those who are not infected with HIV, get them into PrEP programs. So, Hyman, it's great to have you here today, and look forward to hearing your talk.
Great, thanks, Mike. I appreciate the invitation to talk a little bit about implementation of PrEP in clinics. And I think that sounds like there's a mixed audience in terms of PrEP experience. So hopefully you can touch on some elements that are useful for everyone. So I have no relevant disclosures. And these are my learning objectives. Talk about PrEP candidates, describe some of the PrEP regimens available for different populations, and how an approach that we use to determine and to support patients and clients making decisions about what might work best for them, particularly given that new PrEP agents are on the horizon. Hopefully in the next couple of months, we have injectable PrEP as an option, and then monitoring patients on PrEP and supporting adherence. So I think it was really exciting when the U.S. Preventive Service Task Force gave PrEP a grade A recommendation, which with the Affordable Care Act follows the requirement that insurers cover the full cost of this for prevention. And so this was really, from a policy standpoint, tremendous in supporting PrEP implementation and covering some of the cost issues that have really been central to PrEP before it was became generic. And so these are some of the key elements we think about when we're initiating someone on PrEP and continuing them on PrEP. It really is focused on the laboratory elements. The clinical evaluation for many of our patients is quite minimal. I think some of the evaluations that we do for diabetes are more complicated than some of the evaluations we need to do for PrEP. And then financing is a huge piece that I think providers, clinicians, and prescribers are often totally unaware of the implications for. And we often have seen this come up as we've seen patients who are trying to initiate PrEP, go to the pharmacy, are told they have an $1,800 bill that they have to pay to pick up their Truvada at the time. And so these are some of the elements that we try to integrate into how to start someone on PrEP, and then continuing them on PrEP with sort of a quarterly visit schedule, which is actually for a lot of our patients who might not be engaged in care frequently, is an opportunity to do other things like ensure they're up to date on vaccinations, do some counseling, substance use counseling, those kinds of things. So as I mentioned, access is really something that impacts our patients tremendously. And in a lot of our qualitative work, it's something that patients also often describe as one of the biggest barriers, and providers often don't mention as an issue. So talking to the patients about how they're going to cover the cost of not only the medications, but also visits and labs. We're doing HIV, STI testing, and patients, if they get a $500 bill, will be a barrier, even if the cost of PrEP is covered. So the grade A recommendation has been really helpful for coverage for those who are insured. And there are folks who don't have access to insurance for a variety of reasons. And there are assistance programs that are in place to help cover some of those costs. Some of the states actually have programs. So there's a PrEP app program in California, for example, that is focused on addressing some of these access issues, and will cover the cost of visits and labs and the cost of medications to really cover the full cost of PrEP access. And then many patients are actually eligible for insurance, but need support going through the process. So providing that type of help. And this is something that I think leaning on the team-based model within our clinic settings, having staff that can help with patients navigate through that insurance. And so when we think about navigation, really thinking about how do we help people get onto PrEP, and this can be passive or active. There's been some studies looking at how well navigation works, which to helping people start on PrEP. The pilot studies show that some of the active, more strength-based navigation resulted in more people starting PrEP. But the data has actually been quite mixed on the role of navigation, mostly focused on sort of insurance and cost issues and its impact on helping people get onto PrEP. In one study in our clinic settings here in San Francisco, navigation was actually associated with faster PrEP initiation in a clinical setting, and it really was our navigators doing a lot of counseling and education on PrEP and dispelling some of the myths that some of our patients may have had about some of the toxicities related to PrEP. Current CDC guidelines, and I'm going to go through in a second, the proposed updated guidelines really focus on three groups, MSM, heterosexual women and men, and people who inject drugs. And you can see that these are sort of the criteria, and really talking about high numbers of partners, which is, up for debate what high is, inconsistent or no condom use, commercial sex work. And for people who inject drugs, having an HIV positive partner, sharing equipment, not in drug treatment, which has been associated with HIV acquisition, and then risk of sexual acquisition. The revised guidelines are actually much simpler, and so really focus on any bacteria, having an HIV positive partner, whether that's a sex partner or injecting partner, a bacterial STI, or history of inconsistent or no condom use. The new recommendations will also sort of highlight that universal PrEP education and recommendation to inform all of our sexually active patients about PrEP, and then to offer PrEP to anyone who's asking for it. If somebody's asking for PrEP, there might be activity that's not being disclosed, and then providing this universal PrEP education without sort of framing this in a risk context is really sort of underpins the new CDC guidelines. And one of the things that when we're doing work with our providers here, many of our primary care clinics, is really talking about like, how do you talk about sex without talking about risk, and really taking a sexual history focused on partners, gender of partners, and really reflecting the gender spectrum, types of sex that people are having, whether condoms have a role or not in their sexual activity, past STI history and testing approaches, and then ensuring that for people who are able to become pregnant, desires for pregnancy and prevention methods. So this is one of the examples that we talk about with as far as the language that we use. I think a lot of our language around PrEP is being for high-risk people. High-risk sexual activity really has undermined our approach to try to get this rolled out more broadly, because a lot of people don't consider themselves high risk. It's often seen as relative and to other people in their networks. And so what we've tried to do is focus on a sexual health-based approach, talking about it, reducing anxiety and taking control, and that risk is not part of the conversation that we have with our patients around why PrEP might be a good option to consider. And I like to highlight also that risk reduction counseling is oftentimes discussed as something that we should be including in our discussions around PrEP. And I just wanted to highlight that there are several studies. This is the WARE study, which was a randomized controlled trial of 5,000 clinic patients in STI clinics in the US, that had a brief individualized patient-centered counseling, which is actually probably more than what most of us do as providers in clinics. And the bottom line is it just didn't work. And there are other non-randomized studies and review studies and systematic review studies that have shown that for HIV uninfected individuals, that risk reduction counseling is not effective. And in this AWARE study, actually, there were higher STIs among MSM who received counseling compared to those who didn't. So in some ways, it's not only doesn't work, but it might be harmful for some of our population. So risk reduction counseling is not something that that I would recommend doing in the setting of PrEP. Supporting individuals in achieving their sexual health goals and supporting adherence are important, but risk reduction counseling is not effective. And the same was for Explore. This is the largest study that was completed in the early 2000s. And this was an intensive one-on-one counseling for 10 sessions with quarterly maintenance counseling. And again, that there was no effect on HIV acquisition. So the IPREGAY results, I just wanted to go over briefly since those were covered earlier, really focusing on the efficacy of the on-demand PrEP with really high relative reduction in HIV cases, and that individuals were not taking daily PrEP during this time period, on average about 18 pills per month. And then the Prévenir study, which was an open label prospective study that also showed high impact on incidence with approximately 361 HIV infections averted. So really providing the evidence for on-demand PrEP as an option for our communities. So in the US, 211 with TDF FTC is recommended by the IAS-USA guidelines. It is in the new updated recommendations from CDC, but is currently the only licensed indication by the FDA. And that for daily TDF FTC for cisgender women and people who inject drugs is the option. So for 211 PrEP, these are some of the considerations that I think about for who might be a good candidate for it. And so daily PrEP is for anyone. 211 has really only been studied in MSM. If somebody has chronic hepatitis B, thinking about the safety for ensuring that you know the Hep B status and provide vaccinations for those who might still be at risk. And then the planning around the need to have at least 2 hours advance to be able to take the 2 pills versus daily where no planning is needed. And this has been actually, we've seen a lot of back and forth during the COVID pandemic as people's sexual patterns have changed. There's been more switching back and forth between 211 and daily. And then the forgiveness idea around whether or not it's forgiving of missed doses and ability to adhere to sort of the 2 before and 1 24 and 48 hours after sexual activity. And then as part of our discussions, we talk about condoms and condom effectiveness. And so there are some data that condoms are about 70% effective, and in heterosexuals, it's about 71 to 77%. And then in MSM, from data from 2 large cohorts, suggesting about 70% effective. And the MSM data is actually quite interesting in that this is 100% condom use. So if condoms were reported to be used anything less than 100%, then there was actually no evidence that they were effective. For initiating PrEP, some of the baseline lab testing outlined here. So what we currently recommend is doing a 4th gen, preferably 4th gen HIV antibody antigen assay within 7 days. I think I definitely in a clinical setting, if somebody is 8 days since their last test or even 14 days and has no symptoms of acute HIV, I've definitely started PrEP for people in that scenario. And then HIV viral load testing if it's available. And especially if there's a concern for any acute HIV symptoms, is the sort of the baseline testing that we do. And then rapid-based testing has actually been really useful in a lot of our clinical settings to do same-day starts. There's some implementation considerations, particularly for hospital-based clinics where it's dependent on the laboratory to cover the CLIA for the point of care testing. And so getting buy-in and support for the rapid blood-based testing. And then with anyone who has acute HIV symptoms or is initially having an ability to send out for either laboratory-based 4th-gen testing or HIV viral load testing as well. Here in San Francisco, we actually have access to a pooled HIV viral load. So they pool 10 samples together, run the viral load testing, and if the pool turns positive, all of those samples are tested individually to identify the individual who was likely acutely infected. This is just a brief timeline of the HIV infection and where you would see the positive test. So with our RNA testing, we can see a positive test out at about 14 days. And then with the earliest antibody tests in about 20 to 25 days. So really trying to capture, particularly in places where there's high testing. So in our community here, over 96% of MSM are aware of their HIV infection. So our community is enriched for people who might be acutely infected or have early infections. And so using this pool strategy has been best for our local epidemiology. And then other testing we do at baseline is kidney function testing. The only test really needed is creatinine. Some clinical sites also do ALT or AST testing as well, given concerns about potential Hep C. But oftentimes here we're doing a metabolic panel. It's easier to order, and in some clinic settings, particularly for Quest, ordering an individual test is actually more expensive than ordering the panel. So you will likely get abnormalities on those metabolic panels that might need some follow-up, but those are generally how we approach the kidney function testing. We do 3-site gonorrhea and chlamydia testing and do a syphilis serology, and then hepatitis B, A, and C testing, and then pregnancy testing for all of our patients who are able to become pregnant. And as we prescribe PrEP, we generally just confirm, of course, that somebody is HIV negative and doesn't have any acute symptoms, and also actually doesn't have an indication for post-exposure prophylaxis. So definitely had individuals coming in for PrEP who actually have PEP indications, and then doing the baseline testing so that we can transition them directly from post-exposure prophylaxis to pre-exposure prophylaxis. And then for all populations, and I think this goes back to some of the decisions and discussions around TDF versus FTC. So daily TDF FTC with 2 refills. We have some data in our clinical settings that the lower number of refills associated with more discontinuations. So trying to minimize gaps that somebody might have in their PrEP use. We've also seen providers that have prescribed a year supply of TDF, and there was no follow-up testing that was done. And so sort of the sweet spot seems to be about 90 days, and that's what's in CDC guidelines as well as some of the other guidelines. And then daily TAP FTC, again, this is for rectal exposure primarily, so MSM or transgender women, and then on demand with TDF FTC, again, 90 days. And the reason we recommend 90 days is because individuals might go back and forth between on demand and daily PrEP, and want to make sure that individuals don't lose access to PrEP if they're using it more than just on demand. So for the follow-up testing, generally every 3 months with the quarterly visits. And then as Rafi had mentioned, the role of potential viral load testing for in the setting of cabotegravir LA use. And I think locally, what we're considering is whether or not we would just do the pooled viral load testing for all of those cases in 2 of our clinics here, our municipal STD clinic and our clinic called Strut, which is in the Castro. This is already done where pooled viral load testing is done on all individuals who are tested for HIV. So integrating that into the flow for cabotegravir, and we'll be able to evaluate whether or not that is able to identify infections that would have otherwise been missed by our rapid testing. Again, going back to rapid testing as an option for follow-up lab testing as well. And then the kidney function testing every 3 to 6 months, STI screening. I generally do that 3 to 6 months. I do have some patients who I do STI testing every month, and syphilis serologies as well as needed. And then annual HCV screening for MSM, people who inject drugs, or others who might be at risk for hepatitis C. And so if somebody has a negative antibody, HCV antibody at baseline, then we would do antibody test screening. If somebody has either been cured of hep C, then we would do, and has a positive antibody, we would do viral load screening. And there's been several studies that have actually shown quite high incidence of hep C among particularly MSM populations within the US and within Europe. So this is something that we do at least annually. The other advantage of the metabolic panel, if you do see LFT abnormalities, those are often been associated either with syphilis or with incident hep C. So another advantage of potentially doing AST/ALT with the quarterly labs. And this is a slide that John Michel had presented at one point. This is one of probably the most common scenario that we encounter, where somebody has ambiguous or discrepant HIV test. There's a positive HIV antibody screen, a negative confirmatory test, and maybe the viral load is pending. So what we generally do is repeat all the testing, including RNA testing, and try to use a different platform if possible, and then have to make a decision about what we do with their medication. So the options are really to continue PrEP if they've been highly adherent, and that provides protection, but you risk developing resistance if somebody is truly infected. You could stop PrEP and reassess HIV status. This might facilitate diagnosis, but the risk of infection is high, particularly if somebody has continued sexual activity. So really counseling and discussing with the patient around their ability to abstain if that's possible, and to allow to assess their HIV status. And then start ART, where it might be associated with drug-related adverse events, although I'd say with the current regimens we have available, that's less of a risk. And it also makes it somewhat difficult to confirm the diagnosis. There is a funded PrEP line that's based here in San Francisco that's available for these questions, and also access to research testing, including some ultra-sensitive HIV viral load testing. We've seen a lot of PrEP discontinuations, and I think some of the data suggests that ongoing PrEP use is around 50 to 60% at best in many of the populations in the US. And I think this gets to Rafi's point about daily PrEP doesn't work for everyone, and that adherence, and particularly ongoing adherence, is actually not at the level that we would hope it would be. And then we've seen, particularly during COVID, as things have opened up, even prior to that, cases where individuals stopped PrEP and then subsequently were diagnosed with HIV. And so something that we want to really support individuals to maintain and continue on PrEP and reduce barriers to access. And we've seen this in our clinics here as well, and we've seen some racial disparities as well as gender disparities, and that is something that we want to try to support and make it easier to have people continue PrEP and make our systems better fit what people might need. So one of the ways that we've thought about this is thinking about task shifting. So having non-prescribers provide education, adherence counseling, the financial and navigation support, standing order protocols so that that patients can get their testing done at their first visit without necessarily seeing a clinician initially, and then minimizing the clinical evaluation if it's indicated. So, for example, we have our navigator will talk to our patient in one of our clinics, do the adherence counseling, order the labs, and then send me a telephone encounter, and I will talk to the patient, start him on PrEP same day. So those are some of the ways that makes it better for patients to be able to start PrEP quickly. And then streamlining the delivery, so allowing our patients to have standing orders, to just drop in and get testing as needed, supporting self-collection of swabs, either at home or in clinic bathrooms. And then we've used express visits at a couple of our clinics here where patients just drop in, do their labs, and then see their clinician annually. So it really reduces the barriers for patients. And telemedicine has really expanded during COVID. It's definitely allowed access. And for some populations, I think it's not a universal plus for all of our patients, but for those who can engage with it and it matches their needs, I think it is really, really promising. We have several companies that are already providing telemedicine-based PrEP. We don't know yet the data on how well it works for uptake and persistence, but texting, and particularly for some of our younger populations, is also a potential tool. Home testing, just a brief a comment on that. So there are some labs that are supporting home testing. And then in California, actually now insurance health plans have to cover it. So I'm at the end of my time. So just wanted to brief summary and looking forward to the Q&A session. So we should offer PrEP education to everyone, not talk about risk, give people choices, and make it easier for them to start and stay on PrEP. Thank you for your time.